Welcome to Fact versus Opinion. Today in this video, we are going to discuss about a very important clinical trial called Ischemia, which is published in 2019. So the Ischemia trial is done to directly compare the invasive strategy like bypass surgery and angioplasty against medical management or conservative approach. So many of the physician as well as patient were under the belief if they are very aggressive at the earliest stage of the disease, means invasive strategy like bypass surgery and angioplasty, if done at the earliest stage in patient with stable angina, will be able to provide some benefit or incremental benefit over medical management in terms of heart attack and can prolong life. Well, this is an idea which is prevalent in the society. In spite of many trials for the past 4 decades have clearly proven beyond any doubt that invasive strategy will not able to offer any benefit over medical management in terms of reducing the risk of heart attack or death. In spite of it, I would say around 500,000 surgeries and angioplasties are done on stable patient every year across the globe. Now, in spite of the negative trials, why there is a high prevalence of this procedure in stable patient? The reason is many of the interventionalists argue that the high risk group, where the bypass surgery and stenting would provide incremental benefit, were not included in this previous trial. So to answer this, the Ischemia trial was designed and it took almost 8 years to recruit close to 5,000 plus patients. And then they randomized them into 2 groups. So with all that, let's come to the trial itself. So what the trial does is they recruit a high risk group of patients who are considered to be benefited with the implementation of these interventional procedures at the earlier part of the disease. So now let's look at the demography of these patients who have been recruited by the Ischemia trial. 90% of these patients have severe chest pain even on routine activity, and second is almost 80% of the patient have multivessel disease, so they have more than 2 vessels involved, and 87% of the patients have proximal lesions. So the lesions are so proximal, so the large area of myocardium or heart muscle is suffering from the lack of blood flow. And finally 86% of the patient, when they undergo an imaging technique which can able to identify the lack of blood flow to the muscle, is very severe. So 86% of these group of patients have severe reduction in blood flow to the myocardium. Now looking at this demography, I wouldn't even doubt any interventional cardiologist or a bypass surgeon would leave this patient with medical management alone. Immediately they are wheeled into an operation theatre and either a stent or graft will be placed with the argument that doing this invasive procedure at this juncture of the disease will save their life as well as prevent a heart attack. Now, in this trial, these group of patients, almost around 5,179 patients, have been categorized into 2 groups which has been equally distributed. So one group is given to the interventional cardiologist and cardiothoracic surgeon. So they immediately underwent an angiogram, and any procedure which is deemed to be fit to them, either it is a stenting or bypass surgery, is done in this group of patients. But care was taken that all the vessels which are diseased are addressed. So no vessel is left untreated. This is called complete revascularization, which is done in this group of patients. So the other group of patients, intervention is not done and the patients were asked to continue their medical management. Now what they did is, after a follow-up of 4 years, they want to find out the number of patients who have heart attack in both the group, which is a primary endpoint or a hard endpoint for this study. So if you look at the death, 145 in invasive group and 144 in non-invasive. So 145 death has happened in patients who have undergone invasive procedures like bypass surgery and angioplasty, and 144 death has happened in patients who are managed with medical management alone. So absolutely there is no difference in death. It means in a patient point of perspective, doing interventional procedure will not prevent any death. The death is equally distributed in both the group 145 and 104. So there is no change in the death rate. Now the another secondary endpoint is event. Event means when you have a patient with coronary artery disease, other than death, there are a lot of complications can happen because of the disease itself, and these are all called events. For example, patient might be repeatedly hospitalized because of severe chest pain, which is called unstable angina, or they could have been hospitalized because of heart failure where the heart pumping function has significantly come down, or they would have died because of other cardiac complication, or they could have admitted for cardiac arrest and they could have been resuscitated. So they are not dead, but they have a cardiac arrest. So these are all the events which we are expected in patient with heart disease, and any treatment. In fact, if you want to go for an invasive procedure, we assume this event will be significantly reduced in the group where medical management and over that bypass or angioplasty is done. To the surprise, the event is also equally distributed. So there is no significant difference between the event which happened in the medical arm when compared with the invasive arm. So you have two important things. After invasive procedure, in this part of high risk group patient, there is no change in the death rate or change in the event rate when medically managed patient were compared with the medically managed with bypass surgery and angioplasty. So the procedures are done over the medical management. So medical management still done in this group also. So there is no significant difference. So the only interpretation possible is adding a highly invasive procedure did not change the outcome of the disease. Then why do we do the angioplasty and bypass surgery in this group of patients? So when you looked at the soft endpoint, it means quality of life, exercise time. So there is a mild to moderate increase in quality of life in patients who have undergone this invasive procedure. And as a patient perspective, if I am a patient, I would not undergo a procedure which is high risk, which can offer me only some around like 20 seconds of increase in walking time, which is highly unlikely a patient will go for this procedure. Well, this didn't end here. Now, if you look at both this endpoint, event and heart attack death, both are similar. Now, there is another shocking finding. In the first 6 months of the interventional procedure, the people who are on the invasive group have higher event death and heart attack who undergone the procedure. Now this is around 2% higher than the conservative arm. So let me put all this in a simple term. So if I am a cardiologist, I want to give a consultation or counseling to you to undergo a bypass or angioplasty. As a factual evidence, this is what I have to tell the patient. Look, I want to put you under a procedure called angioplasty or stenting, or it could be a bypass surgery. So the reason I am doing is just to have you improve some improvement in quality of life or decrease in chest pain. Offering this procedure will not change your chances of getting into any cardiac events or hospitalization. Doing this procedure will not have any effect on your survival. It is purely because of some quality of life. At the same time, I need to caution you because this procedure also can increase your chances of getting heart attack or death or any other event, which is 2% higher than if you are in medical management alone. So this would be an unbiased counseling to a patient who is stable, and you are asked them to go for interventional procedures like bypass surgery or angioplasty. Now, putting all this together, there is another shocking finding in this trial which could be unbelievable for patients. Now, when I said when we do the bypass surgery and angioplasty, the first 6 months, the death or event rate is 2% higher than compared to the medical management alone. It depends upon one thing called definition of heart attack or definition of myocardial infarction. To the horror of patients, The definition of myocardial infarction or heart attack has been tweaked in such a way it will favor invasive procedure, because if the regular definition of heart attack has been utilized in the trial, which is called procedural heart attack, then the heart attack or the death raised up to 10.2% in the invasive arm, which is only around 3.7% in the conservative management. So it is almost double the risk of you getting a heart attack or death during the procedure, which is called procedure related complication. This has not been explained in detail to the patient. This is now this has been tweaked to such a level so that it will not have any impact on the trial by saying the definition of heart attack can be done by two enzymes. One is creatine kinase and second is troponin. Even though it is clinical, you just remember the two enzymes which will be leaked into your blood and can be identified in your blood if you have a heart attack. But in this trial, procedural related heart attack, you need to establish the same amount of enzyme have to be elevated 35 times higher than normal for me to declare it is a heart attack. But in a simple definition of myocardial infarction, even a small increase would be called as a heart attack. So I think for a patient, it doesn't matter whether it is a high level of troponin or high level of creatine kinase. A heart attack is a heart attack. If that is a criteria, then the end result of the trial would be completely different. It would say conservative management is much superior to that of an invasive management like bypass and angioplasty in stable patient. And doing this invasive procedure will almost increase your risk of death and heart attack without any benefit on your future heart attack risk and death. Now, the trial is around 4 years follow-up, and in 4 years follow-up, the study is concluded with no benefit has been shown in the bypass and angioplasty arm. So altogether, there is only some quality of life improvement this surgical procedure can able to offer over medical management. In simple term, it could be also a placebo, because a previous trial like Courage and Barry trial has clearly shown after 1 year this subjective improvement of quality of life or reduction in angina has also waned away. So after 12 months, the medical management group and invasive group both behaved in a similar fashion. So we have to be very careful when we are going for a procedure like bypass and angioplasty when you are stable. So as a conclusion, I would want to tell the patient, if they are going for a consultation and if your consultant is offering you interventional procedures like bypass and angioplasty, I would like you to ask them 3 questions. I think these 3 questions, the answers should be given in a written format so that you could be safe. And if it is followed, I think 80% of the invasive procedure can be avoided in the society. Now let me go. If you are going into a consultation room, the first thing you need to ask a patient, ask the physician or your cardiologist, is to let them know whether you are stable or unstable. It's not very difficult. If you are going to the cardiologist consultation room, you are stable. And if your relatives are going to the cardiology consultation room and if you are hospitalized, you are unstable. So first let them write you are stable. And second important point is they should categorically write and say that all the medical management has been tried and exhausted and you are still highly symptomatic. This is a second important thing they have to write. And the third point is they should write there is a difference between opinion and fact. This is why all the video is about. As a fact, they should say as a third point, there are some evidence in the literature that if you do bypass surgery or stenting, it will provide some benefit in reducing your risk of heart attack and can also improve your survival. If these 3 points has been written by your cardiologist or cardiothoracic surgeon, then take them to a second opinion and find out whether this fact is okay and recheck it, and then you make a decision. If the decisions are made in these 3 important clinical parameters, I am 100% sure 80% of you who have been asked to go for a bypass surgery and angioplasty can safely avoid it. Now, with all this presentation now, as a patient, I know you might have a very important question. Now you can ask me, doctor, if there is a block, there is definitely a reduction in the blood flow. Doing a stenting and bypass surgery is able to restore the blood flow. Then why does bypass surgery and angioplasty did not work? Now, all the evidence-based medicine or all the evidence-based clinical research put together, there is only one thing is very important. Yes, if you have blocks or multiple blocks, your chances of getting a heart attack is higher than people who don't have blocks. That is a fact. At the same time, if you go ahead and fix the block, you may not prevent you getting a heart attack or death. This is quite a surprising finding. The blocks as such is a predictor of outcome. Means if you have more blocks, you have a chances of getting more chances of getting a heart attack. At the same time, if you go and fix the block, that it will not change anything. Your risk of heart attack and death remain the same. So what is the reason? The main reason which every patient should understand is block is only a marker. It is not something we should treat. This is very complex, and let me put a small example to you so that you can understand it in a better way. Let me say if you have a very high blood pressure, say 220 over by 120, it's a hypertensive crisis. So you go to your cardiologist and then he measured your blood pressure and he asked you what happened. And you tell him, doctor, I have a severe headache, that's why I came to you. But as a cardiologist, look at your blood pressure, it's around 220. You are at a very high risk of having a stroke or a heart attack anytime sooner. Now, if a cardiologist prescribe you a painkiller, let's say a paracetamol, you take the paracetamol, you come home, your headache is gone. But your chances of heart attack and stroke risk remains the same because headache is equivalent to the block. You treat the block and you resolve the block. You treat the headache and resolve the headache. It is a marker, but it did not change your chance of getting heart attack and stroke. The real reason is the blood pressure. Similarly, the real reason for heart attack is multiple blockage. Usually the blockage which is 80 to 90% get the attention and you get fixed by a stent or a graft. But that is not a reason, that is not the block which is going to cause you a heart attack. It is a smaller block, 10%, 20%, 15%, which has been prevalent across your coronary vessels. So these blocks can break and causes heart attack. So this is a reason. If you fix the block, you are not going to change the outcome. At the same time, if the number of blocks are high, the volume or the load of blockage is very high, your chances of getting heart attack is very high. Now, how do you fix these minor blocks? That is where the medical management comes into play. Medical management is the one who can able to change your chance or reduce your chances of getting heart attack or death. So if you are on optimal medical management, enough benefit is already passed on to you. So over that, adding any procedure will not have any effect. So as a conclusion, the benefit of quality of life which you are getting out of bypass and angioplasty could be simply a placebo or what we call as a faith healing. So medical management along with conservative strategy. So as a policy, we have formed a conservative management for patient with coronary artery disease. So 35 days of EECP treatment which is added along with medical therapy, and this have shown not only to improve the quality of life and have shown to significantly increase the blood flow to the heart muscle without this patient going for angioplasty or bypass. So the program we have created is called Ischemic Burden Reduction Program. With EECP and medical management alone can be more effective than this highly invasive interventional procedure which will be exposing you to a considerable risk of heart attack and death itself. The procedure itself is high risk. So to conclude, I would say conservative management along with other non-invasive approach could be a better management in patient with stable angina. Thank you.